Hi, I'm Howard Jack West, and I'm a medical oncologist with a focus on thoracic oncology. I'm an associate clinical professor at the City of Hope Comprehensive Cancer Center in the Los Angeles area. Weaving in of immunotherapy into the treatment for advanced lung cancer, and now many other cancer settings has been one of the biggest advantages in how we manage cancer over the last 5 to 10 years, but it doesn't come for free. We know that these immunotherapies that stimulate the immune system to better recognize and attack a cancer can also cause immune-based side effects. These are essentially an autoimmune phenomenon where the immune system can get confused and attack normal body cells. And so it is essentially like a bystander effect that doesn't occur in every patient, but occurs in a significant fraction of patients. And one thing to understand is that patients can have these immune-based side effects across an incredible range of systems of the body. Essentially, any part of the body that can get inflammation can get an autoimmune inflammation and side effects. This is commonly, in fact, some of the most common side effects of immune-based therapies are fatigue or rash, but the immune system can attack glands of the body, like the thyroid, like the adrenal glands, but less commonly, but severely, possibly, if the lungs are involved or the immune system attacks the liver or the kidneys or even the brain, the colon as well. So a really broad range, sometimes very mild, sometimes more severe. And I will say that in most cases, patients tolerate immunotherapies quite well. A lot of patients have no side effects that they can really perceive, but some do. And if that occurs, there's a range of ways to manage it. For people who have mild symptoms that they barely notice and that don't interfere with their activities of daily living, you can continue the immune therapy and just pursue supportive measures. Maybe they have a bit of a rash and you give a topical medication. Maybe they have mild diarrhea and you can take anti-diarrheal medications. So it can be very mild and you just give a little supportive medication to help address the symptoms, but continue at the same pace without any changes or delays. Once the symptoms become more moderate, what we would call grade 2 in our system of assessing immune-based side effects or overall side effects of our treatment, we would continue to pursue supportive measures, but we would generally delay immunotherapy and consider adding steroids, which are immune suppressing medications that can dampen the immune response. When patients have more severe symptoms that start to really challenge organ function, if it's severe enough based on lab tests or based on things like liver function, breathing gets compromised because of inflammation in the lungs, something called pneumonitis. In these cases, we will discontinue or at least delay for a prolonged period of time the immunotherapy. We'll definitely have people on steroids to dampen the immune function, may add other medications to suppress the immune system. If patients have been on a low to moderate amount of steroids and the side effects escalate, we can go up on the dose. But once you get into this grade 3 or 4 side effects, this is a setting where we generally do not have patients go back onto immunotherapy if they recover from this with immunosuppression. There's some exceptions for things like thyroid function, where you can just take medications and get back to essentially normal functioning. But when patients have autoimmune hepatitis involving the liver, nephritis involving the kidneys, pneumonitis, these are side effects with significant challenges to organ function, that we generally do not re-challenge patients and have them resume immunotherapy once they recover or at least improve from these, based on the introduction of immune suppressing drugs. So as a general concept, if the symptoms are mild and not very bothersome, you can treat through and just add a little supportive medications. If they're moderate, you can add steroids, but you might delay the immune therapy. And if it gets better, you can often resume the immune therapy. But once it becomes more severe and really a threat to people's ability to live their lives, or overall life-threatening, we do not resume treatments. We give much more aggressive immune suppression, and we have patients stay off of immunotherapy after that. It's important to also know that some patients who have a significant set of side effects or autoimmune side effects from immunotherapy can have a sustained benefit from immunotherapy, even if they remain off of immunotherapy for months or even years after that. And so in many cases, if patients do improve, we aren't in a rush to resume any treatment, because people may get the sustained benefit of immunotherapy even when it was discontinued at some point in the past.